Okay, without any delay, we're gonna welcome you to our third session of the 7 SSR conference that include interesting lecture by our senior consultant. I want to welcome our chairperson to the third session, Dr. Mansour Al-Azmi. He's an internal medicine and rheumatology consultant, Vice President of Saudi Society for Rheumatology, Deputy CEO, Prince Mohammed Medical City Al Jouf, and Dr. Mushabbab Al-Ghamdi, Associated Professor of Medicine, Dean College of Medicine, University of Bisha, Medicine and Rheumatology Consultant, King Abdullah Hospital, Bisha. Welcome our chairperson.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for this introduction. It's my pleasure to introduce Prof. Suzanne Latar. Is she around, Dr. Suzanne? Prof. Suzanne Latar, she's well known to all the rheumatologists. صراحة المعروف لا يعرف. She's a professor of medicine, division of rheumatology, King Abdulaziz University, Jeddah. Board certified at Royal College of Physician and Surgeon of Canada. She was a fellow of American College of Rheumatology. She published many research in multiple national and international journals. Prof. Suzanne, the floor is yours.
بسم الله والصلاة والسلام على رسول الله سيدنا محمد أشرف الأنبياء والمرسلين. First of all, I would like to thank the Saudi Society of Rheumatology for inviting me to present, let's say, a wonderful review, because it was what a year. We had an awesome year. How to move this? How to move the slides, please? Okay. We had a wonderful year. It was along with the pandemic. We had a wonderful year. And now what I'm going to do with you, I'm going to present and review everything from the year 2000 to 2020, from the journals of rheumatology as well as the general medicine. I will go mainly with the published data and with the abstract that I thought, except, and I repeat, except, I will leave it for the expert people, the COVID-19. I will go mainly with the priority data, with the data that I thought it have a clinical importance to us as a clinician, as an impact in our behavior. As well as what I did, I surveyed the disease expert. So I'm going to go over the ACR, the update from the ACR guideline, from the EULAR guideline, and some published data here and there from the different journal with regard to different diseases in the form of rheumatoid arthritis, spondyloarthropathy, gout, and the reproductive medicine as well. So first of all, our favorite topic, our famous topic within the last couple of years are the JAK inhibitors. We cannot pass any review without talking about the JAK inhibitors, and last year in spondyloarthropathy. So the JAK inhibitor have been evaluated for spot treatment. Only in ankylosing spondylitis, only upadacitinib have been approved by the EMA in 2021 for the treatment of ankylosing spondylitis. And in PSA, both the tofacitinib, it's not new, since 2017 we have been using it. It's approved by the FDA and the EMA in 2018 for the treatment of PSA, and UBA just in 2021 for the treatment. Filgotinib, it's still under investigation with regard to the treatment. Now let's go over the upadacitinib efficacy and safety for active spondyloarthropathy patient. It was presented as an abstract in both the ACR and the EULAR this year. But you know something? The data with regard to the upadacitinib in AS, it's not new. It has been published within the Lancet in 2019. At that time, patient with ankylosing spondylitis who had an active disease of past time more than 3.6, and we know that more than 3.6 is considered to be an active, a very active disease. The nice thing about the result, they didn't only look at the ASAS 40, as Dr. Waleed mentioned earlier. We don't look at the ASAS 20, it's a mild, but we go for a higher endpoint, which is the ASAS 40. In addition to that, they looked into the MRI finding, which is an objective finding, and it was a positive. Now, what I'm going to present here, that was presented, as I mentioned, is in the ACR as well as the EULAR, excuse me. Within the ACR and the EULAR is the interim analysis, which is at 64 weeks. So the results show that there was a significant improvement with regard to the ASAS in addition to the patient-reported outcome. And the patient-reported outcome that showed over here is the patient global assessment and the PASS-5. But you know always that whenever there is a primary endpoint, at that point, even the patient who have been receiving the placebo, they switch into the treatment group. And if you look at the red arrow, those patients who have been switched from the placebo to the treatment or the drug group, they catched up, and their endpoint actually improved. So whenever I advise you, whenever you read about a certain medication, this is the way I look at it. First of all, I look for subjective improvement in the form of the ASAS 40, which was met, i.e. the primary endpoint. Number two, you know by the FDA and EMA, for the past couple of years, no single drug is approved until it's showed if there is an improvement in the patient-reported outcome. So the patient-reported outcome, indeed, in the form of the pain, the PASS-5, the patient global assessment have been improved. And the radiological involvement, it wasn't within the interim analysis, the 64-week, but it was in an abstract that was presented at the ACR at 104 weeks that show MRI improvement. Again, subjective, objective clinical, and objective by the MRI finding. Moving on, upadacitinib with regard to for the active PSA patient. It was presented at the ACR and the EULAR, presented by Ian McInnes, and it was published in the New England Journal of Medicine just in March 2021. And actually, what they looked at, we had 5-arm, the UBA15, the UBA30, of course, it's not the treatment dose, and there's a placebo as well as the standard of care, which is the adalimumab. And the primary endpoint was at 12 weeks, which is the ACR 20 versus the placebo. Now, we know always in the secondary endpoint, you may have more than 10 points, but then once you have a positive result, we consider it as the key finding. And in this case, actually, the upadacitinib 15 milligram and the 30 showed an improvement, and it was superior to the placebo. Is that surprising? Absolutely no. Come on, it's a placebo. But what it showed that it wasn't inferior to the adalimumab within the ACR 20. And the 30, again, it's not the treatment dose. It was superior to the adalimumab. Again, look at the way I look at each new drug. Subjectively, there is an improvement in the ACR 20. The PSO, the skin, and that's what our patient complained from. There was an improvement in the PASI 70, 90, 100, as well as the patient-reported outcome. And the radiographic, there was a decrease or an amelioration of the radiographic progression by the total sharp score. Now, if you would like to know more about the safety, you have to come up tomorrow. I'm presenting the launch of upadacitinib, the ReInvoke, which is going to be at 8 p.m. here at this hall. So please stay tuned. Now, we cannot pass this year without talking about the IL-17 inhibitor. I have to admit one point. Neither Novartis or Lilly have anything to do with the table I'm going to show you in a second, which is this one. This is done by me. I always say to myself, لا يؤمن أحدكم حتى يحب لأخيه ما يحب لنفسه. The way I explain it to myself, I like to present it to you. So we have two main head-to-head trials. There's the EXCEED with regard to the secukinumab and the SPIRIT head-to-head with regard to ixekizumab. Now what we knew, and I repeat, what we knew from before, that by the EXCEED, the DMARD were not allowed, and it was at 52 weeks. And there was an ACR 20 as a standout or the primary endpoint. Now the SPIRIT head-to-head for the ixekizumab, there was a composite, the combined for the ACR 50 as well as the PASI 100, because we know that the IL-17, it worked within the skin. Now the DMARD were not allowed, and the timing at that time was a maximum of 24 weeks. And these are the domains that have been involved, and we knew that it improved in PSA. So what did the last year added to our knowledge? Well, you could see in a second, the axial symptom. We have to think about it. So within the ACR, there was a competition. First of all, there was a safety and tolerability of the ixekizumab versus adalimumab. The 52 weeks result from the head-to-head comparison in patients with active psoriatic arthritis. The endpoint was the composite, as we said, the ACR 50 as well as the PASI 100. Now, the reason of this abstract, it showed the safety of the drug, the long-term safety comparison to the adalimumab. We know it is effective. We just want to know if it was safe. That's what I am concerned in my patient. So first of all, the frequency and the type of adverse event was consistent with the previous trial. And if you look, if it was orange arrow, it goes with ixekizumab. If it was a purple, it's more with adalimumab. Compared with the previous data, it's shown that in certain aspects, the adalimumab carried more side effect with regard to the malignancy as well as the serous infection. And that was published by Ian McInnes as well as Smolin in July 2020. Now, Novartis replied back by showing the MAXIMIZE trial. And what does the MAXIMIZE trial? It showed an objective improvement and objective changes with regard to the axial symptom by the Berlin score. And the dose that have been used is both the 300 milligram as well as the 150 milligram. Now the primary endpoint at week 12, improvement in SS20. No surprising, I want the SS40. So indeed, the SS40 significantly was higher versus the placebo. And it was sustained up to 52 weeks. And finally, there was a reduction in the Berlin score. Now, Lilly replied back by showing the efficacy and the safety of the ixekizumab versus adalimumab in patients without DMARD. Yes, I would like to see that, because initially when I looked at the data, I said, they're using DMARD, so perhaps that giving an added point. But if you look for the post-hoc analysis, for patients have been using methotrexate in week 52, the efficacy was similar across all the multiple endpoints, regardless, and I repeat, regardless of the concomitant use of the DMARD. And please pay attention to the red point, because it showed that there was still improvement in the composite endpoint as well as the PASI. The only thing over here in the last figure, adalimumab had a lower response as monotherapy, especially with the PASI, that's shown in purple. Novartis replied back with regard to objective changes in the synovitis confirmed by the ultrasound. We always look for the synovitis by the ACR 20, by clinical examination, by the DAS, but it's always nice when I have it confirmed by objective finding. An instant over here is the ultrasound. So the primary endpoint, there was a change in the form of the synovitis by the GLOS score. And the secondary endpoint, even the enthesitis by the SPARC improved. So what did last year added to that table? For instance, the most important point was shown in red. In Novartis, in case of secukinumab, the MAXIMIZE trial showed an objective as well as subjective improvement with regard to the axial symptom in PSA patient. Now for the ixekizumab, although it's not published, but there was a post-hoc analysis showing that there is a subjective improvement in the inflammatory back pain. But we don't have any data with regard to the MRI finding, and I'm sure it's going to be published at some point. Now, with and without DMARD, it showed that it's the same. And even there is a data right now with regard to the nail PSO. Let's move on to rheumatoid arthritis. Now, a couple of publications as well as abstracts have been presented last year that carry an importance for me and I'm sure for you. First of all, we know for the JAK inhibitor, it carries an increase in the risk of the herpes zoster in comparison to the control. Is it disease related or is it related to the drug? We don't know, but there is an increase in the risk. We all keen and eager. We're waiting for the killed vaccine. The Zostafax, we know that it carries a risk for activation of the disease because they're immune suppressed patient. But in this case, which is the Shingrix, I'm looking forward for it. So we would like to know the response for the patient who are receiving JAK inhibitor. How well is it? Well, the immunogenicity of the herpes zoster vaccine have been evaluated in RA patient treated with JAK inhibitor versus control. 40 patients with RA, they were taking TOFA compared to 20 that they were taking the control. And actually, there was 20% almost or 25 decrease within the immunogenicity response. So does that give us a clue that we should help the methotrexate before and after giving the Shingrix vaccine? This is something yet to be answered, but we should put it and consider it in our mind. Over the past years, almost 4 years, whenever I go to the ACR meeting, there's a specific booth. I have to go and look at it, is this one. Despite our effort, despite what we're trying to do to our patient, we know that only 40% of the patient almost they reach remission in rheumatoid arthritis. And there are certain patients, despite whatever treatment you give, whatever biologic, different mechanism, they still have a high disease activity. And they don't know, and you don't know what to do. And they tell you, please, Doctora, with anything you could, I'm willing to pay anything to minimize my disease activity. So this is a device. It's a non-pharmacological treatment, a non-invasive vagal nerve stimulator. It's not new. It's been in the market almost more than 5 years, as I said. And it was presented at the ACR and published in January 2021. So before, it was like an iPhone or like a smartphone in your pocket, and the patient connected to their body. But the new, right now, they have an ear set, and the patient could target the pain control with it. If you look, the trials that was made in 30 patients who failed DMARD and the biologic, at week 12, believe it or not, their DAS decreased by 1.44, as well as there's an improvement of the ACR, as you could see from these bars, from 53 to 33 and 17%. I'm not advertising for the company. I'm not advertising for the non-pharmacological management. What I'm saying, why not? When I have myself an active patient despite using 4 or 5, maybe I would consider this. Now, this ACR review cannot pass without speaking about the big topic last year, which is the new ACR guidelines for the treatment of rheumatoid arthritis that was presented in the last ACR, and they will term it as the 2020, but yet it's still under peer review. Now, I don't have the time to talk about all the ACR recommendation and the guideline, but at least I want to point out some messages. Before, when we started being a consultant, there are certain things that it wasn't written neither in the textbook or even within the publication data. We used to go and ask people who have been in the field for many years, let's say 20 years, and tell them, please, doctor, if a patient developed this and this side effect, or they were intolerant, what to do? What I liked about this new recommendation, that actually we know it's a disease expert. They're not evidence-based. They're based on 81 PICO questions. And again, they're not evidence-based, so they're expert opinion. What I like, they stated clearly an options and the patient was intolerant for methotrexate. For an example, you could switch to the sub-Q form. You could split the dose into 2. You could increase the folic acid treatment. Things that we have been asking our seniors and people having inexperience, they stated over here. And what they stated and they recommended and they advised for to use a short, and I repeat, a short-term steroid. You know something? This is not new. Even the EULAR guideline, they recommended in the 2019 to use a short-term steroid, not more than 3 months. And not only when you start treatment, it's even when you switch from a DMARD toward a biologic, from the DMARD to another biologic. Their statement was, let the patient feel comfortable and not only unsafe. Lupus nephritis, or lupus. We have been dealing and we have been challenged with the treatment of SLE for many years. Because do you know how many treatments that there are really FDA approved for the treatment of lupus? Aspirin, steroid, believe it or not, neither plaquenil, mycophenolate, cyclosporine, rituximab, none of them are FDA approved for the treatment of SLE. They're all off-label use. So whenever I see that there's a new drug that is FDA approved over the last year, which is the voclosporin and the belimumab that I'm going to show in a second, I open my eyes widely and look at the data. So it's not new. The company they were smart. They used the drug in an indication of SLE, which is objective measurement. That is the lupus nephritis. I could measure the creatinine. I could measure the urine creatinine ratio. I could measure the GFR. Unlike the other measurement of the SLE, such as the SLEDAI, which is a very broad. Now, it was based on 2 studies, the Aurora as well as the Aura LV phase 2. And actually, what it showed that there was an improvement in the voclosporin plus, I repeat, plus the standard of care treatment in comparison to the placebo. And you know what? Patient did tolerate it very well. And even the toxicity was similar and comparable to the placebo group. With regard to the belimumab, it has been there in the market for a while to use in patients without lupus nephritis. And adding it to the secondary of care, it improved the primary endpoint, which is the efficacy of the renal response. In addition, some of the secondary endpoints, such as the complete renal response and the PER and the time of renal-related event. It was FDA approved last year, and the patient did tolerate it as well. Gout treatment. The problem with gout, you know, for many years ago, there was a propaganda and a big talk with regard to the febuxostat. We like the febuxostat. We like allopurinol. We use it in patients sometimes with a chronic treatment. But you know, since it came out in the New England Journal of Medicine published that it may increase the cardiovascular event, well, some of us backed up in patients with cardiovascular risk factor 1 or 2 and 3. I'm not going to take a risk on that. Well, the FAST trial, which was presented at the ACR as well as published in December at the Lancet 2020, make these rumors to rest. So, the major cardiovascular event over 4 years for the febuxostat, it was not inferior to the allopurinol with a hazard ratio of 0.89. And the mortality was 7 versus 8 in the febuxostat versus allopurinol group. You know something? Whenever there's a big concern, I like to look out at the details of the data. And what it showed that the dropout rate for the FAST was low, which was 6% in comparison to the care that was high, which is 57%. So it was opposite to the care study. Another retrospective review that I thought, you know something, it's excellent, that showing patients with gout who are taking prophylaxis, which sometimes we give, depend where you live, in which part of the world, 0.6 versus 0.5 milligram twice a day. This study showed it was comparable. Giving the patient 0.6 milligram twice a day, it's the same as giving it as 0.6 milligram once a day. So why not? So I could tell my patient, you could just take 1 pill a day. It's going to give you the same effect and the same gouty flare as taking it twice a day. There was a new guidelines for reproductive health in rheumatic disease and musculoskeletal. And you know something, the majority of us, we know that, and we know how to deal and handle. But they just emphasize and they updated some of this information. Well, first of all, they could additionally recommend to treat lupus patients with low dose of aspirin unless your antiphospholipid antibody is positive, then you have to go with anticoagulation. For men, they almost could use anything, and it wouldn't affect their conceived ability. For an example, but they were against the use of cyclophosphamide, thalidomide prior attempting consumption, and it's okay to use TNF inhibitor, Imuran, as well as hydroxychloroquine. and no MMF for 6 weeks. And with regard to the methotrexate, on the bottle itself, it say, please stay away 6 weeks before, and in the guideline, it say 3 months before. And you know, at the end, it's your physician judgment. I would not take the risk for fetal malformation. That's why I like to be in the safe side for 3 months. In conclusion, tamam? Okay. In conclusion, number of agents are available for the treatment of spondyloarthritis, as well as for treatment of rheumatoid arthritis. Upadacitinib in AS patients who are biologic naive, and secukinumab in axial PSA. In rheumatoid arthritis, the guidelines did help us to know how to treat and how to deal with our patient. More options. The good news is for treatment of lupus nephritis patient. Fibuxat is not inferior to the allopurinol with regard to the cardiovascular risk. And finally, more to come in the pipeline. I repeat what I say. What a year. It was a wonderful year. بحلوها وبمرها. What a year. What it gave us more thought and more time in order to think what we could do different to our patient. وبحول الله عز وجل, me, you, and all of us, we could do something to our patient. Thank you so much for your attention.